Good morning, students. Welcome to online video class. Today's subject is disorders of the thyroid gland. Particularly today I will discuss hypothyroidism. Before going to hypothyroidism, let us have a look into the applied anatomy and physiology of the thyroid gland, functional anatomy and physiology. The thyroid gland produces two related hormones. One is thyroxine or T4 and other is triiodothyronine or T3. So thyroid gland produces two important hormones, thyroxines, T4 and to a lesser extent triiodothyronine. These hormones play a critical role in cell differentiation and organogenesis during development and help maintain body temperature, metabolism in adults. Overproduction of thyroid hormones is called thyrotoxicosis, and underproduction of the thyroid hormones is termed as hypothyroidism. Today's subject is hypothyroidism. When the thyroid gland is enlarged, we call it goiter. Goiter is the enlargement of the thyroid gland. This is the figure. You see, thyroid gland has got a control over the pituitary hypothalamus. You see, this is the hypothalamus, then it is pituitary gland, this is the thyroid gland. This thyroid gland had two lobes and connected by isthmus. This pituitary, from the hypothalamus, this thyroid releasing hormone is secreted, which stimulates the anterior pituitary, from where this TSH, thyroid stimulating hormone, is produced. And this hormone comes to the thyroid gland and stimulates production of the T4 thyroxine. And in the tissues, this T4 is converted to T3 in the peripheral action. So this is the regulation, and you see in hormones in endocrine gland there is a feedback. Here also, when the TSH is more, that will give rise to feedback to the pituitary, to the hypothalamus. So this is a classical example of regulation of hormones synthesis and a feedback loop. So that will give rise to negative reaction to signals to the pituitary gland and to the hypothalamus. Thereby the secretion of this T4 and T3 will be reduced. So this is the histology, how this iodination formed and thyroid gland and thyroid hormone is produced. The thyroid gland consists of numerous spherical follicles composed of thyroid follicular cells that surround secreted colloid. The follicular epithelial cells synthesize thyroid hormones by incorporating iodine into tyrosine on the surface of the thyroglobulin Tg. The thyroid axis is a classic example of endocrine feedback loop. Hypothalamic TRH, thyroid releasing hormone from the hypothalamus, stimulates pituitary to produce TSH, thyroid stimulating hormone, which in turn stimulates thyroid hormone secretion. The thyroid hormones act via negative feedback to inhibit TRF and TSH production, as I have mentioned earlier. Let us once again see, this is a thyroid follicle, and this is the colloid, and these are the cells. And inside the cells, how this iodine is trapped, and there is formation of T3 and T4. This is monoamino tyrosine to 4-amino tyrosines inside the follicular cells. This had been depicted very nicely, what I mentioned earlier. So this is the thyroid follicle, and how this T3 and T4 is produced inside this thyroid follicle. So there may be nodules of the thyroid gland of various forms, and that may give rise to cancers which are amenable to detection by physical examination or by imaging. Thyroid consists of two lobes. It is lobes, not lines, connected by an isthmus. It is located between the cricoid cartilage and the suprasternal notch anterior to trachea. 4 parathyroid glands are located posterior to each pole of the thyroid. So this is the anatomy, applied anatomy and physiology of the thyroid gland. Once again, the thyroid gland consists of numerous spherical follicles composed of thyroid follicular cells that surround secreted colloid. The follicular epithelial cells synthesize thyroid hormones by incorporating iodine into tyrosine on the surface of thyroglobulin. The thyroid axis is a classic example of an endocrine feedback loop. Hypothalamic TRH, thyroid releasing hormone from the hypothalamus, stimulates pituitary to produce thyroid stimulating hormone TSH, which in turn stimulates thyroid hormone secretion from the thyroid gland. Thyroid hormones act via negative feedback to inhibit TRF and TH production, as I have mentioned earlier. So, hypothyroidism. Hypothyroidism is a state of deficient thyroid hormones secretion by the thyroid gland. So, when the thyroid hormone secretion is deficient, is less, the state we call it hypothyroidism. This is due to disease of the thyroid gland, that is primary hypothyroidism, or less commonly due to disease of the pituitary or hypothalamic diseases, secondary hypothyroidism. So, primary hypothyroidism means is a disease of the thyroid gland itself, and secondary hypothyroidism means the higher control, that is pituitary and hypothalamus, is a disorder. So, hypothyroidism is a common condition affecting women more frequently, 6:1. And autoimmune disease, that is Hashimoto's thyroiditis, iatrogenic causes account for 90% of the cases of hypothyroidism. These causes I will elaborate later on. So, deficiency of the thyroid function will lead to hypothyroidism. It may be primary, it may be secondary. Primary means it is due to the thyroid gland itself and defect in the thyroid gland itself. Secondary means this is due to defect in the pituitary or hypothalamus. So, here is a picture of this patient. These are look at the face of this patient. You will see that there is puffiness of the face, the periorbital edema there is, and the outer third there is eyebrows are deficient. So, the skin of the face is thick. There is plethora, these are found in foreign ladies, but not in our country. So, altogether this sort of faces is called typical faces of hypothyroidism. Now, what are the causes of hypothyroidism? So, I have already mentioned the most important cause is autoimmune destruction of the thyroid gland, resulting in deficient thyroid hormones. of which most important is Hashimoto's thyroiditis. This Hashimoto's thyroiditis may have some autoimmune disease, and there may be some swelling of the thyroid gland, and ultimately this destruction of the thyroid gland and leading to spontaneous atrophic hypothyroidism. This is the same process. So autoimmune thyroiditis, the most important cause of hypothyroidism, of which Hashimoto's thyroiditis is important. Then spontaneous atrophic hypothyroidism. Then iatrogenic causes. That means this cause is by the doctors who are causing hypothyroidism. So that a patient has got hyperthyroidism or Graves' disease, we are giving radioactive iodine ablation, and this ablation becomes more, the amount is more. As a result, we are causing hypothyroid. Or there is partial thyroidectomy. So after thyroidectomy, there is less amount of thyroid hormones. So it is caused by this operation, post-operative hypothyroidism. So iatrogenic causes. Or we are giving some drugs that will cause transient hypothyroidism, amiodarone or other drugs. So these are three causes iatrogenic. One is radioactive ablation, then thyroidectomy, then drugs. There may be other causes too: thyroiditis, subacute decoarvans, iodine deficiency is an important, and some congenital is reduced thyroiditis, of which most important is autoimmune thyroiditis. You have to remember this: Hashimoto's thyroiditis, spontaneous atrophic thyroiditis, or iatrogenic, either thyroidectomy, post-thyroidectomy, radioactive ablation, or transient thyroid due to drugs. Then secondary hypothyroidism may be due to where thyroid is intact, there is no disorder, but the pituitary is intact. There may be postpartum pituitary necrosis following labor and PPH. There may be this sort of disorders. We call it Sheehan syndrome. So it is not uncommon. Previous days when obstetric management was not so good, so we used to see Sheehan syndrome, that is secondary hypothyroidism. Now comes the symptoms and signs. On the left hand side there are symptoms, on the right hand side there are signs. Most salient symptoms and signs to be remembered. Patient will complain of tiredness, weakness, easy fatigability. There is dry skin due to deposition of mucomatous substances underneath the skin that will give us to thick, dry skin. Feeling cold, there is intolerance, cold intolerance. There is hair loss, difficulty in concentrating and poor memory. Then patient will have constipation. Then weight gain and poor appetite. Then patient may have dyspnea, hoarseness of voice. If you ask the patient what is her name, and there is hoarseness of voice, even over telephone, hearing this hoarseness of voice, one can assess that probably she is having hypothyroid. Then some disorders, some menstrual disorders, menorrhagia, oligomenorrhea, amenorrhea, like this. There may be impaired hearing also. So these are most important symptoms of thyroid, hypothyroid. Then there may be some important signs. There is coarse skin, cool peripheral extremities, puffy face, what I was mentioning. Then that is called myxedema. Then hands and feet tinglings, diffuse alopecia, and there is bradycardia. Then peripheral edema, non-pitting edema, and delayed tendon reflexes is important. Delayed tendon, ankle jerk, delayed relaxation we call it. Then there may be carpal tunnel syndrome also. There is pain over the wrist joint, and if you press here there will be tingling. So this is called carpal tunnel syndrome. And there may be effusion in the serous cavities, pericardial effusion, pleural effusion, like this. So these are some important signs. There are so many signs also. So symptoms and signs. And before going to the investigation, let us see once again another picture. Yes. You look at this patient face, there is similarly puffy face, then eyebrows are deficient, then periorbital edema, there is whether goiter is present or not I cannot say. So coarse features of faces. So this faces shows that this is a myxedemous faces. So the investigations, this most important two investigations are done. Number one is TSH, thyroid stimulating hormone is elevated. As I mentioned that there will be stimulation of the thyroid gland by the pituitary, TSH will be elevated. So this is an important investigations of hypothyroidism, and we have to see also serum T4 level. So low T4 level and elevated TSH is the investigation which clinches the diagnosis of hypothyroidism. If you only do TSH, sometimes we will miss some other conditions where we call it subclinical hypothyroid. Here the TSH is elevating, but the T4 level is not very much low. So this condition just is going to be low. This condition is called subclinical hypothyroid, and here treatment will be given or not, there is a difference of opinion. Some says that if the TSH is more than 10, then you can treat. Some says no, you watch and do every 3 or 4 months TSH and T4 and then treat. So that's why it is better to investigate both T4 and TSH level. Then ECG, which may show low voltage, and STT changes and TOF changes. So the ST segment depression and TOF inversion may be found with low voltage. And sometimes a Hashimoto's thyroiditis, if we say automatic or not, if there is a TSH is high, T4 is not low, in that situation TPO antibody can be helpful for the diagnosis. So initial investigations is do an investigation T4 and TSH. In the diagnosis of hypothyroidism, T3 investigation is not necessary. You just do T4 and TSH. Management. Treatment is with levothyroxine. We have to replace the thyroid which is deficient, that should be replaced. Start with a low dose of levothyroxine 50 microgram per day for 3 weeks. Thereafter increase up to 100 microgram per day, and finally a maintenance dose of 100 to 150. So 100 and 150 is the maintenance dose, and we have to titrate with 3 months interval by the report of the thyroid TSH level and T4 level. So levothyroxine replacement is the dose. Start low dose and titrate and gradually increase. But in younger patients, you can give, it is safe to initiate higher doses, 100 milligram. But patients with ischemic heart disease, thyroxine replacement should be introduced at a further low dose, 25 microgram, and then gradually titrated. But in pregnancy, an increased doses are required. So this is how to replace the thyroid hormone, and low dose then gradually increase, or in young patients you can give the proper dose, but in ischemic condition you can start with low dose and gradually increase in this hormone. Then subclinical hypothyroidism, what I was telling you. Serum TSH level is raised, but serum T4 and T3 are normal range. So this is not a normal condition. As TSH is rising, but it is raised. So subsequently there is some process inside the thyroid gland that will give rise to thyroid destruction. So after 3 months, the T4 will go down. So this is a raised TSH with normal or low, high normal T4. It's a situation of subclinical hypothyroidism. Clinically, there may not be features, but this will ultimately turn into hypothyroidism. This condition may go for many years, and TSH is higher than 10 milliliter, or if the TPO antibody is present, then a trial of thyroxine replacement is appropriate. So this condition, some schools believe, some physicians wait for their T4 to go down and TSH to go above 10 ml, then start replacement therapy. So this subclinical hypothyroid means there is process of hypothyroidism. TSH is rising, but T4 is yet to be low, and there is no symptoms of hypothyroidism. Then another condition is very, very important, that is severe hypothyroid state. It is called myxedema coma. Severe hypothyroidism in elderly may present with confusion, coma, and hypothermia and hypoventilation. There will be hypoglycemia and hyponatremia too. So severe elderly patient having hypothermia, hypoventilation, coma, confusion, and hypoglycemia, hyponatremia, one should suspect this myxedema coma. A high index of suspicion is necessary to diagnose this condition. Then there may be pericardial effusion, there may be cardiac failure. So treatment is, myxedema coma is a medical emergency, and treatment must be started before biochemical confirmation. You send the blood for testing and don't wait for the testing. You start clinical on the basis of clinical grounds the treatment for the diagnosis, and there is gradual rewarming is necessary as there is patient is very cold. Then give oxygen, give IV fluid very cautiously, but you have to give levothyroxine, liothyrin on 20 microgram intravenously, to be followed by further injection of 20 microgram 3 times a day, and associated with, along with, you can give hydrocortisone intramuscular 3 times a day. So this is a very, very serious situation. Unless you suspect and there is high index of suspicion, you miss the case, and whenever you are suspecting, you send the blood for the investigations, but start treatment with this. If it is not available, then you can give through Ryle's tables and the thyroxine a loading dose. Now let us see one other patients. Yes, here in the right picture, the face is a puffy, the periorbital swelling, loss of eyebrows, and so if you are asked what do you do and what do you want to examine more, you are suspecting this is a case of hypothyroid, but there is more points, more features are to be added. So if you are asked what do you want to examine more, you will say yes, I will examine the skin, whether skin is dry, whether it is rough. I will examine the leg for any non-pitting edema. I will talk to her for voice, whether it is a hoarse voice or croaky voice. I will see the pulse, whether bradycardia is present, and I will do an ankle jerk, whether it is delayed relaxation present or not. If all these things are present, so your confirmed diagnosis is myxedema. So on the left hand side is the other opposite. This is the hyperthyroidism, the eye science. I will take up this class on the next day. So if that patient is presented to you as a short case, just look at the face and you are suspecting is a hypothyroidism, then next question would be, what do you think about the causes of hypothyroidism? Answer would be, sir, it would be autoimmune or autoimmune thyroiditis, that is Hashimoto's thyroiditis, or spontaneous atrophic thyroiditis. This is most important. Here, as the another patient is there, who has got a goiter. Yes, you see this patient. This patient has got a swelling of the thyroid gland. So this is a goiter. So it is hypothyroid plus a goiter. So whenever there is a goiter with hypothyroidism, we think of this is autoimmune thyroiditis or Hashimoto's thyroiditis. So similarly, the question was that in this patient, if you have to ask here, you look at the throat, look at the face and give your diagnosis. And if it is said that it is a case of hypothyroidism, you will say, yes sir, this is goiter plus hypothyroidism, so it is a autoimmune Hashimoto's thyroiditis. But here they are the florid features of hypothyroidism, the coarse features of the faces, the eyebrows are red, there is outer third of eyebrow is less, and there are other features, periorbital edema. So this is a case of faces is a case of mixed edema. Can you spot the diagnosis of this patient? This baby has got a protruded tongue, there is intelligence is poor, pot bellies and hypothyroid. So this is a case of cretinism. So this is hypothyroid in child, this is a case of cretinism or cretin. So I have shown you different cases of hypothyroidism. So to sum up, so hypothyroid is a state of deficient thyroid hormones secretion by the thyroid gland. Hypothyroidism may present with thyroxine hormone is related to the metabolism. So as their metabolism is reduced, so there will be cold intolerance, there will be deposition of myxomatous tissues in the skin, then skin will be thick, then there will be faces, typical faces, there will be delayed relaxation, there will be menorrhagia, metrorrhagia or menstrual disorders. There are so many symptoms and signs of hypothyroidism. The cause of hypothyroidism, most important is autoimmune thyroiditis, we call it Hashimoto's thyroiditis, and in the latter part it will lead to destruction of the thyroid gland, atrophic thyroiditis like that, or due to iatrogenic condition such as the post-ablation therapy or post-surgery therapy or following giving drugs. Then the investigations of choice is serum T4 and TSH investigation is very, very important. There will be high or elevated TSH and low T4 in a classical case of hypothyroidism. But if TSH is high but not above 10 and T4 is normal, then this should be a case of subclinical hypothyroidism. And there may be sometimes patient may present with a comatose condition, and an elderly patient we should suspect a thyroid coma or myxedema coma. This is a very, very serious condition, and we have to suspect and treat with the clinical suspicion and sending some investigations. And thyroid may also present with some goiter, and we will take another class of hyperthyroidism and goiter, and that we will discuss everything about that. Thank you. Now I can show you one patient who has been brought from the ward. She is on treatment with eltroxin for 3 years. So all the florid features are not present, but still he has got some important features. You see what this face is. You see there is some periorbital edema. The skin is something coarse like that, and the skin here also is coarse, and she has complaining of some tingling sensation on both the lower limbs, both the upper limbs, both the hands, maybe due to entraped neuropathy, and she had some disorders of your sleep and alopecia also, and she is intolerant to cold. আপনার শীত কেমন লাগে?
শীতকালে শীত বেশি লাগে,
আর অন্য কালে কি?
অন্য সময় অল্প হলে অল্প লাগে,
শীত লাগে।
হ্যাঁ।
And so intolerance to cold is there, and I cannot show you on the other findings, particularly delayed relaxation of jerks and other features, but we have to see as he is receiving the drug L-toxin for 3 years, some sort of improvement is there. That's why all the florid features are not present, but I can show you the where this thyroid gland is enlarged or not. ঢোক গিলুন তো দেখি। So here the position of the thyroid gland, butterfly like. So on deglutition the gland will go upwards. ঢোক গিলুন দেখি। So there is no visible thyroid swelling at present. So it is non-goitrous. If it is thyroid, it is non-goitrous thyroid. So how to palpate thyroid gland is very important. I will show you when there will be a goiter. You have to inspect the thyroid gland from front, from the sides, and then you have to palpate the thyroid gland from the back. Let's tilt like this. We start palpating like this, just lower border, dhogilun. Then you palpate like this, press like this, then like this, whether any nodules are there, whether if there is a goiter, whether it is soft, rubbery or like that. And lastly, you have to see whether there is extension to the chest by percussion, and you have to auscultate here to see any rui. So this is the examination of thyroid gland. So this is a case of treated hypothyroid. Her TSH was raised, but after taking 75 microgram of L-toxin, she is doing well. So she is a treated case of hypothyroid. Next day we will show you a patient of florid hyperthyroidism and a patient of goiter. Thank you.